Thank you, Dr. Mangrum. Dr. Mangrum has always been almost like one of my children, and I'm so very proud of her. So anyway, thank you very much for inviting me to speak today. And I have no disclosures as it pertains to this topic. And as I think most of you know, the baby boomers are aging, and as a result, we are starting to see huge numbers of people come into the elderly age group. And one thing that I found very interesting was 10,000 baby boomers will turn 65 every day until 2030, and that's currently going on. So you can see from these population profiles, the one on your left is a 1980 US population profile, and you can see that there weren't as many people that were in the upper and older age groups, whereas the 2025, which is seen on the right, it's much more of a rectangular type of shape. So there are, not only are people getting older, they are also staying more active. Unfortunately, we still use a lot of resources at the end of life. According to Medicare, 30% of expenses for Medicare go in the last 6 months of a patient's life. As you can see on this lifespan, and this is the gray area under the curve, equals 100% of all healthcare expenditures over a lifespan. But what's interesting is with Medicare patients, less aggressive interventions are associated actually with better quality of life, and sometimes even a longer life period at the end of life. But what we're actually seeing is that there's an increasing intensity in interventions. COPD patients with higher utilization of mechanical ventilation was seen in 2009 as compared to 2000. And 10% will have surgery in the last week of life. But that doesn't seem to be what really patients want to have. Less than 10% say that they want to spend their last days in the hospital. And less than 17% even want potentially life-saving drugs that would make them feel worse. And approximately 75% want palliative medications, even if those medications would be life-shortening. Over my career span of about 30 years, I've seen a change in priorities. It's no longer just about preventing mortality. Now we're trying to look at quality of life and making sure that people are able to be functional when they recover from either injury or illness. Geriatric patients, as we know, that frailty does predict their outcome. There's much higher mortality if you have, for any given ISS or AIS if the patient is frail or if they have chronic critical illness. And survivors of trauma, no matter whether they're elderly or if they're even young, can have long-term impairments, whether those things are PTSD, cognitive dysfunction from like head injury, or decreased health-related quality of life. And many never return to their baseline function. And in many times, we see an increased mortality at 1 year of life. In 1991, the government enacted the Patient Self-Determination Act, which required that health care providers give patients information about the right to make advance directives. However, this really it only was in very few places in the country that it took off. And so in 2014, when the IOM published Dying in America, they said in this publication that a person-centered, family-oriented approach that honors individual preferences and promotes quality of life through the end of life should be a national priority. And since then, we're beginning to see a change in how we approach patients. Most of the time when people are talking about end of life, it's usually because there's been a long-term illness, whether it's COPD or heart disease or cancer. And so these are trajectories of death that have been looked at more in a medical type of population. You have a short period of decline, which is mostly in a cancer diagnosis. Prolonged dwindling usually occurs when you have someone who's frail and demented. Then the bottom one, down here, has long-term limitations with intermittent serious episodes. This is going to be mostly things like heart and lung failure. But when we're talking about trauma, even acute care surgery, emergency general surgery, it is a very different thing. You have a normal functioning human being who then is immediately driven into, with a motor vehicle crash, comes in, and they're dropped into the medical maw. They're at the mercy of the call schedule as to who they get. It's not like you can develop a relationship with a physician. You don't even get to choose a physician. And so it's a very different ability to talk to patients about what end-of-life wishes they want. And we know that patients that have a very high risk after either emergency surgery or trauma, and these are the people such as the elderly with multiple comorbidities, end-stage renal disease, dementia, frailty, those that have an ASA of either 4 or 5, or those that even have a pre-op that they're already a do not resuscitate, nursing home residents. And on the right, which I don't expect you to be able to read, is a whole long list. It just shows you that there are so many things that can contribute to the high risk after emergency surgery. In a NSQIP study, NSQIP being the National Surgery Quality Improvement Program, they looked at DNR versus no DNR patients in over 25,000 patients over the age of 65. The patients that had a DNR were those that were older, they were female, they were underweight, they had functional impairments, they were chronically ill, and they also had twice the number of ASA4s as the other group. And as you might suspect, their 30-day mortality was markedly increased, 36.9%. They had about the same number of complications as the other group, but their mortality after a major complication was again significantly increased. Over 56.7% died after that major complication. So you need to talk to patients about end-of-life care. But surgeons, at least I was never trained in how to communicate these things. And this, I don't know if you can read the caption, but it says, "There's no easy way I can tell you this, so I'm sending you to someone who can." This is a quote from Dr. Susan Block, who's chair of the Department of Psychosocial Oncology and Palliative Care at Dana-Farber Institute in Boston. And as surgeons, like most physicians, we usually view the primary purpose of a discussion with a patient or family as a way to lay out the facts and options. But she views this as a mistake. A larger part of the task is helping people negotiate the overwhelming anxiety. Whether it's about death, about suffering, about loved ones, about their finances, and there are many worries and very real terrors. And there's no one conversation that can actually cover them all. And arriving at an acceptance of one's mortality and a clear understanding of the limits and the possibilities of medicine is a process. It's not an epiphany. This is taken from Zara Cooper's Pitfalls of Communication. And she looks at all of the different areas that are part of the things that go into how we communicate with patients. That because there's oftentimes a communication breakdown. With surgeons, you can have time constraints that undergoing and trying to get the patient to understand what's going on with what's going on. And many times the cues are there that the patient may want to talk about death or the possibility of death, but we ignore it. And in reality, it's probably because we don't know how to discuss it. And when you have surrogates, the surrogates may not necessarily understand what goes on with the patient, and they're afraid to take away anything that might give the patient more time. That even if the doctor tells them that there is no hope for going further, 64% of surrogates felt that the patient, that they did not believe the physician. And even when they were told that there was absolutely nothing else, 18% still wanted something to be done. And with the patient itself, it depends on where they're coming from, their cultural differences, their spirituality. All of these things enter in how we communicate. And sometimes it's systems. The system, the uncertainty of what the prognosis is going to be, whether or not the surgeon or the surgeon surrogates have the time to be able to sit and talk with the patient. All of these things add pitfalls to our communication process. And there's a number of different ways that we've gone through of trying to provide information. And again, I've practically come through this during the course of my career. Originally, many, many years ago, we saw the paternalistic model, where the doctor knows best. I'm sure that some of you have seen on the reruns the Marcus Welbys, and where the doctor always knew what was going on, and he would tell the patient what they needed to do. And that, we've gone away from that, thank heavens. We went to an informative model, think consent process, that we give the patient all of the information and we let them make the decision, even though they have no medical training. And so what has come about over the last few years in becoming much more of an area of an attempted trying to teach our residents and trying to come out and have people figure out how to talk with patients is something called an interpretive model or shared decision model. And an example of this would be using a best case, worst case tool, where the surgeon will talk to the patient, tell them what their two options are, and then give them an idea of, given their underlying morbidities, and their morbidities that they already have, where I think as a surgeon you're going to come on the best case that can happen if we do surgery, or the worst case if we go through surgery. And the same thing for your other option, or however many options you are. And what that does is it gives the patient and their family something that's tangible. And it's not something that has to be given and say this is an all or nothing phenomena, that at any point in time, if we find that you have a best case and you're home in a week, great. But if you happen to be that worst case, then we can revisit at a later time frame. And maybe you may not want to go through the part where you're in the ICU for 3 months and then on to a nursing home where you'll die there. And so shared decision making, you have to clarify the patient's understanding of the injuries or illness, the prognosis, and what are the expectations for recovery. What are they expecting to be able to get out of this treatment? You have to identify the patient's priorities and goals. You also have to determine the health states that the patient would find unacceptable. And you also have to continue to affirm your commitment to the patient's well-being. Atul Gawande, if you haven't read his book, Being Mortal, I would wholeheartedly recommend it. He has made very pertinent observations on our relationship with patients and at the end of their lives, their families, and their abilities. It really is something that I think should be required reading for any surgeon or any intensivist that takes care of patients in their end-of-life days. And he notes that we have had a reluctance to honestly examine the experience of aging and dying. And for the patient, we've actually gotten to the point where we're doing more harm to people than what we made in benefit. And this quote comes from Being Mortal. Our decision-making in medicine has failed so spectacularly that we have reached the point of actively inflicting harm on patients rather than confronting the subject of mortality. And if end-of-life discussions were an experimental drug, the FDA would approve it. Ann Mosenthal is the chair of surgery at Rutgers and has been a big proponent for palliative care. She's also a board-certified palliative care medicine physician. And she introduced into the ICUs at Rutgers the ability for having an interdisciplinary model for palliative care in the trauma and surgical ICU. And that has gone into what you will see further in the lecture of what was presented. She presented these last weekend at the TQIP National Conference, a preview of the best practices for palliative care in trauma. And so I've taken the liberty of taking some of her slides and to give you an update on what's coming out. They're not published yet. They were only presented last week for comment, and so there may be changes coming out. But palliative care, we always think of palliative care as only for end of life, only for those people who are dying. But it's an approach which improves the quality of life of patients and their families when facing life-threatening illness through the prevention, assessment, and treatment of pain and other physical, psychosocial, and spiritual problems. Domains of palliative care involve many, many different things, as you can see here. It can be physical, it can be structures and processes, psychological and psychiatric, social, spiritual and religious, cultural, end of life, and ethical and legal. If you define the domains by patients and families, the clinical care of the patient allows maintaining comfort, dignity, personhood, and privacy. Communication should be timely, ongoing, complete, clear, and compassionate. You need to address what the condition is, what the prognosis is, what the treatment plan is. And then patient-focused decision-making, aligned with the patient's values, their care goals, as well as their treatment preferences. And you have care of the family, and that's sometimes some of the things that I think we forget. You need to have open access and proximity to the patient. The patient should not be shut off from their loved ones. There needs to be interdisciplinary support in the ICU. And there needs to be bereavement care for the families of patients that have died. Some of the key principles that you see with palliative care: it should be delivered in parallel with life-sustaining care throughout the continuum from the time of injury or illness onset on through recovery, as you can see here. Other key principles include the patient and the family should be considered a unit of care, not just focused just on the patient, not just on the family, but the two together. Best practices requires that it be an interdisciplinary team. And palliative care, especially with our acute care surgery, whether it's trauma or emergency general surgery, should begin in the emergency department. And acute care surgeons and nursing staff should have basic competencies in primary palliative care, pain, and symptom management at the end of the life care. In the emergency department, so what do you say, what can you do for palliative care? But think about it. That first hour, you have somebody who's imminently dying, maybe of severe brain hemorrhage or brain injury or hemorrhage. You've got the person who comes in dead to the emergency department. Now the family will need to be taken care of. Or they may have gone on to the OR, to the ICU briefly, and died there. And you need to have the ability for communication of bad news, bereavement, and care of the family. And the elderly, it begins with making sure you assess for their advanced directives. How many times has a patient come in and been subjected to very aggressive care only to find out that they had a pulse and they didn't want any kind of resuscitation? There needs to be a rapid goals of care conversation. This is different than the person who comes in with a known history of cancer or COPD over a long period of time where you get to know your physician. And you also need to make sure that all care is aligned with what the patient's wishes are. Inpatient patients, all patients should have pain and symptom relief and emotional and psychosocial support for both them and their families. All patients should be screened for early palliative care. And all patients should have healthcare proxy and advanced directives identified. So if it isn't possible in the emergency department once they become an inpatient, that needs to be looked at. You need to find out who's the surrogate decision maker in case. So inpatient palliative care on admission, this is in less than 24-hour period. Who's their healthcare proxy? So who's going to be their surrogate decision maker? Do they have advanced directives or an existing DNR or POLST? Has their pain been assessed? Has it been adequately treated? Has there been family information and emotional support given? And the screen for early palliative care. What's the prognosis? The surprise question. Are they frail? The screen for early palliative care identifies patients who will benefit from early goals of care conversations. And it's based on prognostication, not just the injury severity, but also pre-existing factors. Is the patient frail? And as we heard earlier from Dr. Brown's lecture, it isn't just limited to the elderly that may be frail. Do they have end-stage disease, such as end-stage chronic kidney disease or liver disease? Is death likely or uncertain? Other outcomes, such as disability or poor functional outcome, are also important to ascertain. And then the surprise question. The surprise question is, would you be surprised if this patient were to be dead within 12 months? And so this is the kind of patient that would have frequent admissions. The admissions are prompted by difficult to control either physical or psychosocial symptoms. They may have complex care requirements like requiring IV antibiotics at home or home oxygenation or home vent. Decline in function or feeding intolerance, basically failure to thrive. This is an early palliative care screen. So you look at for trauma. The trauma injury, is it non-life-threatening? Or their disability, it's a non-disabling trauma injury, previous functional status, they've been healthy, no serious chronic illnesses. The surprise question is you'd be very surprised if they were dead at 12 months. And examples would be somebody who's young with multiple fractures and a couple of others. But then if you start to go into potentially life-threatening injuries, potentially disabling injuries, they have serious illnesses as an underlying comorbidity, they're frail, and the surprise question is maybe or no, then these are the patients that would be placed into a Category 1. Category 2 would be a high hospital mortality due to trauma injury. They may have permanent disability or functional outcome incompatible with the patient's wishes. They may have a chronic serious illness, their frailty, their older age, and you would not be surprised if they were dead at 12 months. And those are some of the examples that you can see there. For a Category 1, for a positive screen, within 72 hours, now within 3 days of their admission, you need to have an advanced care plan. You need to have a goals of care conversation with a family meeting. The code status discussion. The pain and symptoms, make sure they're assessed and treated. Make sure there's support for the family. And to have communication as to what those care plan options, you may consider time-limited trials. And you may need to get a palliative care consult depending on what your availability is at your hospital. For Category 2, those that are much more seriously ill, they're imminently dying or expected outcome is unacceptable to the patient, there you're going to focus more on comfort measures, the focused goals of care conversation, DNR, withdrawal support protocols, and again, now you have your pain and symptoms are priority, and you need to have bereavement and spiritual support are more of a priority. This just gives you where you look at all the admission less than 24 hours for all trauma patients, then if it's a positive screen in Category 1 and a positive screen in Category 2. I'm going to talk briefly about defining futile and potentially inappropriate interventions. And this is coming from a policy statement that was published this spring from a Critical Care Medicine Ethics Committee. When there is no reasonable expectation that the patient will improve sufficiently to survive outside the ICU, or the patient's neurologic function will improve sufficiently to allow the patient to perceive the benefits of treatment, that would be considered a potentially inappropriate intervention. Occasionally, you may want to use life-prolonging interventions that may reasonably be considered inappropriate, even if the above definition is not met. Futile should only be used if an intervention cannot accomplish the intended physiologic goal. And clinicians should not provide futile interventions. There needs to be a process-based approach when an intervention that is considered inappropriate is requested by the patient or surrogate. And it comes down to 7 steps. Enlist expert consultation to continue negotiation, give notice of the process to the surrogate, obtain a second medical opinion, hospital ethics committee review, offer the surrogate the opportunity to transfer the patient, inform surrogate of the opportunity to pursue appeal, and then implement the decision. When time pressures of the patient's condition make it infeasible to complete all 7 steps, and the definition of inappropriate care is met, clinicians should refuse to provide the requested treatment and complete as much of the 7-step process as the clinical situation allows. Time-limited ICU interventions may be appropriate, such as dialysis, even if the definition is met, if doing so furthers the patient's reasonable goals of care. Treatment to relieve pain and suffering is always going to be appropriate. I'd like to leave you with some final thoughts. Changing demographics is emphasizing the need for better end-of-life care in acute care surgery. Palliative care is delivered in parallel with life-sustaining care throughout the continuum from injury or illness, onset to recovery. It's not just for those that are dying. You need to treat the family meeting as a skill, just as you would an operation. You have to make the time, sit down, and use a shared decision-making model of communication. All patients should have pain and symptom management and emotional and psychosocial support for both them and their families. All patients should be screened for early palliative care, and all patients should have healthcare proxy and advanced directives identified. Thank you.